So our final session before lunch, I say that, but you're not going to want to miss this. We're going to be talking about personalized and predictive precision healthcare, led by our Chief Business Development Officer, Semi Shen, to moderate the panel titled Precision Health and the AI Imperative.
Thanks. Oops. Good morning. Thanks very much for waiting for this panel. I know we are running a bit late behind schedule, but I promise you this would be a very interesting one. Artificial intelligence, I think everybody has heard a lot about it during these past 3 days, including machine learning, presents exciting opportunities for healthcare transformation and life sciences. It offers enticing prospects for faster, more accurate diagnosis, decision-making, early detection, prevention, and also augmented R&D capabilities. There are many questions around regulation, clinical relevance, and utility, but the market is still growing. The global artificial intelligence in healthcare is expected to grow at an average growth rate of 44% from 2018 to 2025, and is expected to reach about $28 billion. I just would like to show you a slide to see that actually although most people believe it's a hype, there are significant activities going in the field. It's a busy slide and very colorful, but it shows only in the past 5 years, the FDA approvals for AI-based algorithms in medicine. And you can see many different disciplines here, and also many different activities coming from companies big and small. So I briefly would like to introduce our panelists, Michael Howell, Chief Clinical Strategist at Google Health, David Caro, President and Chief of Radiogenomics at HumanLongevity, and Steve Kearney, Chief Medical Officer at SAS. These are all very significant companies in the AI and healthcare space. Therefore, I promise to you that the panel would be quite interesting. First of all, I would like to ask a general question about your company and your approach to AI in precision medicine. So, Steve, would you mind starting?
Sure, no, thanks, and great to be with all of you today. For those of you that don't know, SAS is a 40-some-year-old company that actually started in healthcare. We were the first statistical analysis language. And so when you talk about healthcare and breadth and depth of knowledge, we are with every payer, provider, all Fortune 500 companies, 76 countries in the world use SAS for healthcare. Every federal and state agency uses SAS for healthcare. And so when we talk about what does that look like in regard to AI, precision medicine, we really talk about that it started 40 years ago traditionally with the algorithms, and now it has evolved into really how do you look at, so for example, the preface for this conference or this session was how do you make it predictive, personalized, what does that look like? We would also say you have to have another P, which is production. How do you bring that into the workflow? How do you make that look good in regard to a provider making decisions, the next best action? And that is what we're working on today. So it's using a lot of those techniques. It's seamless to providers. It's seamless to payers many times. But it's using a lot of data, making it interoperable, getting it to the right person at the right time. And, we're thrilled to have sponsored projects such as Project DataSphere, which right now has more than 100,000 patients in phase 3 clinical oncology trials. It's out in the public domain for folks to look at, try to understand, look at this analytic environment, bring in other data sources and analyze it. And so I think when we talk predictive, we're talking augmentative, right? It's how do we make those decisions, and how do we get the information to the individuals that can make those decisions?
That's great. Thank you, Steve. David?
So good afternoon, everyone. I'm David Kerr. I'm the President and Chief Innovation Officer for HumanLongevity. And I'd like to just throw out there that there's a lot of hype and hyperbole right now around artificial intelligence and clinical medicine. And actually, it reminds me, going back to the year 2000 when the first human genome was sequenced, there was sort of equal kind of hyperbole and hype about how this was going to usher in, the new genomic era, personalized medicine. And actually, over the last 20 years, not a lot has entered into clinical practice in terms of whole genome sequencing data. So I think similarly, a lot of hype and hyperbole right now around AI. I think HLI is uniquely situated as a company that's reducing AI to clinical practice. So, if you think about our healthcare system right now, it's still largely sick care. Unfortunately, the way that most chronic age-related serious disease is diagnosed is often because of symptoms. Bladder cancer presents with hematuria or blood in the urine. And I think where we're moving as a healthcare system is really to WellCare 1.0, which is sort of pre-symptomatic diagnosis. This idea that before symptoms present, that we can use imaging, genomics, blood biomarkers tied together with AI to identify disease at its earliest stages. But I think where WellCare is really moving, which I would argue is kind of WellCare 2.0, and this is where our company is focused, is moving beyond pre-symptomatic diagnosis to this idea of previvorship, that based on all of the data that we collect from you, we can predict your risk for chronic age-related disease 5, 10, even 20 years before disease onset, when there's something you can do about it, mitigate your risk, and ideally never get the disease in the first place, this idea of previvorship. So we've reduced to clinical practice a AI model of mild cognitive impairment and Alzheimer's disease, which makes use of blood biomarkers, mesial temporal lobe atrophy, or lack thereof, hopefully, and rare and common variants from whole genome sequencing. And the whole idea is to be able to tell someone not only what is your disease or condition or status right now, but more importantly, what is your personalized risk for chronic age-related disease a year from now, 5 years from now, 10 years from now, and not just your relative risk or population level risk, but what is your actual annualized incidence of getting the disease over the next year, 5 years, 10 years. And I think that's really the promise of AI, and I think it's going to take thoughtful companies like the three on the stage here to actually reduce it to clinical practice.
Thank you, David. Michael?
Yeah, I work at a machine learning and search company based in Mountain View. And we come at this from two traditions. So one are people like me. So I'm a pulmonary and critical care doc. I had about 10,000 visits with critically ill people before I started at Google a couple of years ago, and I ran quality and safety for health systems, which is really operational design of a care environment that is safer and more reliable and better experience. And if you're an ICU doc, you know deep in your heart that there are tons of things that we can do that are preventive, if only we could get there sooner, that are better care. And you know that now that over the past decade, healthcare became digitized, you know that you're overwhelmed with information. And anyone who has practiced for a long time knows a couple of things. You know that there are patients who there's some piece of information in there that you need to help take care of them, but you have a 15-minute clinic visit and you can't find it. And you know that often you're there too late. So that's one tradition, or people like me or my boss, David Feinberg, come out of understanding the problems of actually trying to take care of people. And then simultaneously, inside of Google, a bunch of work on machine learning was developed. And a bunch of the advances in machine learning came out of a research group in Google. And as Google started to see that machine learning made things like search and Gmail better, we started to see fundamental improvements in things like image recognition, and then we saw it in things like self-driving cars and other things. And folks inside of Google who had really invented core concepts in machine learning or discovered them began to ask, where is the place that machine learning could help? And health seemed like an obvious answer. And so we come at this with the question of what is it that it would take to help 1 billion people be healthier? And we think that machine learning and AI has an important place in that, both in the routine delivery of care, in helping patients get access to, most patients can't have access to doctors who are at the Cleveland Clinic, right? Most patients are at places like where my family is from, which is like the backwoods of Alabama. How do we get that expertise there? And then how do we make sense of this emerging amount of data that isn't being used and is being effectively thrown away?
Thank you, Michael. Now I really would like to go more into specifics, into what all those great companies have actually done in the AI in medicine space to really deliver precision medicine, and also what kind of partnerships do you pursue with healthcare systems? Because we all know it takes a village to get this done, and we still see a major disconnect between who actually delivers care and who actually develops the technology, and a kind of disbelief between the two. So, Michael, would you like to start with that?
Yeah, the first one is easy. So we work in deep partnership with health systems. It's very clear that that the best machine learning algorithm in the world, all it does is turn a light red or green, and that the people who care for patients are the people who turn that into improved health. So I'll start there. We focused on 3 big areas. So the first area is around things like genomics and variant calling and protein folding. So we have a pretty fundamental basic science group who works on how do you recast those as deep learning problems. We have a group that works on taking real, true, world-class specialist expertise and making that scalable to the people who need it at lower cost. And I will say that was one of the first projects that our group did, and we've been working in this space for 4, 5, 6 years now. And when our team started, the team wasn't sure that this stuff would work. There have been plenty of times when, machine learning will solve something in healthcare, and it hasn't worked. And so if you look at our group, we tend to publish things in journals like JAMA and Nature Medicine because we want to make sure that we've got it right, and we think peer review helps for that. And so one of the very first things that came out of our group was a JAMA paper about diagnosing diabetic retinopathy better than as well as a US board-certified ophthalmologist in JAMA. And we've done some other things in imaging around pathology or in lung cancer screening with full volumetric 3D CTs. So scaling specialist expertise. And then we have a group that works on how do we understand the electronic footprint that patients leave behind. So a patient who leaves the Cleveland Clinic today, I suspect if you looked at their data, they would have 100,000 or 150,000 data points if you're able to deal with all the notes that doctors and nurses and other folks write. And if you look at most predictive models today, they have 5, 10, 30 factors. One of the things that we've worked on is how do we deal with a true complexity that's already exists, even before we start asking how do we add genomics and other things into that. So those 3 big areas, some basic science work, scaling specialist expertise, particularly around imaging, and then how do we help people deal with the full complexity of the electronic footprint that patients leave.
Thank you, Michael. David?
Yeah, I would just sort of start at a high level, and I'm sure you've heard this probably ad nauseum from a number of speakers, but what are we getting right now for our healthcare investment, right? We're spending $3 trillion on our healthcare system, 17% of GDP growing to 20%. And this is a statistic from Global Burden of Disease. In the United States, if you live to the age of 50, you have a 1 in 4 chance, unfortunately, of not living to the age of 75. By the way, globally, it's worse. It's 1 in 3. So 1 in 3, 1/3 of folks living to 50 won't live to the age of 75. And this is despite our investment, $3 trillion, 17% of GDP. And so you might ask, why is that? And I think principally it's because 98% of our healthcare spend is oriented towards the sick care portion, the reactive portion, the symptom-based portion. Only 2% goes towards prevention. So, we at HLI are working with any institutions, companies that are interested in kind of moving the needle moving that sort of transformation from sick care to well care, and so that's academic medical centers, that's concierge practices, that's small and medium-sized hospitals. But the whole idea is to enable those systems with a health intelligence platform that allows patients to identify their disease at the earliest stage, so that we're not identifying disease after symptoms, but that we're identifying disease pre-symptomatically.
Thank you. Steve?
Yeah, so at SAS, we kind of look at it in two areas, the people and the process. So we've been doing this, like I said, for more than 40 years, and if you look at every clinical trial that's been submitted to the FDA, it has to be validated in SAS. So we have that kind of footprint to understand what other folks were doing in that space and what the work looked like. But what we have found to really operationalize this, if we want to look at AI and true precision medicine, is we need the people on the edge working in IoT and all the other data sets. And what does good look like in that space? And we don't have enough data analysts, enough scientists doing that work. So when you talk about partnership, we actually partnered with Cleveland Clinic earlier this year to bring in 8 universities that were doing the traditional work that you would see, but then to talk with folks here at Cleveland to understand the challenges and then help those students understand the work that they needed to do in this space, train those students, and then to try to get them to come into the healthcare market, because a lot of those data scientists are going into other areas. Matter of fact, in regard to machine learning and artificial intelligence, healthcare, as all of you know, is very far behind. The work that we've done in retail, for example, MasterCard, we do real-time risk in MasterCard while you're waiting for that annoying noise to happen at the machine. 320 million transactions real-time every day, right? Healthcare is not there yet.
Yeah.
But we do have some great examples of that. So when we talk about the people, then we talk about the process. Quite frankly, we've been waiting for the process to catch up, waiting for the compute power. For example, we have people badged at CMS right now because they don't have the data analysts to be able to do the work. But they didn't have the compute power either to run all the Part D claims. And so this morning, I can run all Part D claims to understand what does it look like for opioids and the risk stratification. And then how can I send that out? I can do that real time now because we have the compute power and our analytics are not limited by that. So we have to really understand that process, work with our partners, and say, if you don't have the people, how can we come alongside you, educate you, and show you how to use that? Cleveland Clinic, again, is a great example. And actually, I want to get this straight. So in March 2019, there was a great webinar, if you want to reference this, from MIT Sloan Management Review. It's called Building Trust in Data and AI. And what Cleveland did was actually show what the partnership looked like. What did it look like for all the infrastructure? What did it look like for the data sets that are out there? How do they use analytics in that space? And then how do they get the information to the providers, to the systems, to the administrators, so that they can make real-time decisions if they need to?
So thank you for that. I would like to make 2 points on behalf of Cleveland Clinic. One is, I keep repeating it even at this conference, we would like to be the best partner to technology providers, to pharma, to everybody out there, because it takes a village to transform healthcare. The second point is we often receive, in healthcare provider side, we often receive the question of, oh, I can book my travel with a few clicks on Expedia, or you just gave the example of like MasterCard clearinghouse. In our system, it's the sheer complexity of the system prevents us for doing this that simple. So in Cleveland Clinic system, we have 20,000 different type of appointments. These are just appointments for the patients. And I'm not counting the type of procedures we do, type of activities we do behind the scenes. So healthcare is complex. I think we are all aware of it. And we are probably the first and only academic medical institution in the US which had replicated itself in emerging markets. And we have actually transformed a complex system in thousands of miles away from here in Abu Dhabi. Now we are doing it in London. So my next question would be about how do you see emerging markets? Because we see a lot of leapfrogging activity in emerging markets. This happened in mobile phones before they had landlines, they had mobile phones in emerging markets. So how do you see, because of the sheer shortage of people who are qualified to make a diagnosis or to screen billions of people living in different countries, how do you see AI helping emerging markets in your activity? And how do you how can you offer new solutions for them to leapfrog and become the pioneers in AI in medicine? Can you please start, Steve?
Sure. I think we have to start with very specific use cases. And so, for example, the work we're doing in Denmark, and when you ask how do they leapfrog, Denmark has taken the learnings from other countries, and obviously they have a single payer, and applied that by saying, how can we partner and look at simple things like, to your point earlier, what does it look like just for the traditional antibiotic stewardship program? And how would I get that information out to all the providers that would work in this space? And what decisions do they need to make? Well, since they are the entity that actually takes care of all these individuals, just by taking some of the most complex problems that they had and bringing them down just to one environment and understanding the data. The data's telling them a story. What were they missing with the resistance patterns? What did they understand from one area of the country to the other? And so what we were able to do is take that one specific use case with the partner, work with their clinicians, help them understand their workflow, and then start simplifying, automating the processes that we could automate. For example, that's Denmark. In states here in the US, for example, if you're trying to get treatment, just basic treatment for certain disease states, it could take up to 30 days for the prior approval process. A lot of the partners we worked with, we get that to 1 day. What does that look like? Then when you show up to the clinic, you can actually receive the services that you need. So I think you have to start with very specific use cases. You're exactly right. Other countries are leapfrogging in this space. But in some specific use cases, we have some key learnings that we can apply. So for example, sepsis. We have a model where we're working with a large integrated delivery network, 32 hospital system. Just understanding how did the provider get this information into the workflow, and they want it to be seamless, by the way. They don't understand it's AI and machine learning. They just know they received an alert that you need to implement a sepsis protocol. And looking at that information, that data, and the parameters around that, being able to implement that a day earlier saves lives, right? So it's incremental improvements, and it's finding specific use cases with those partners to then try to start making a difference.
Yeah, thank you.
You know, I think in general, the part of the failure of AI kind of reduced to clinical practice and why it hasn't made a significant impact in clinical medicine has been our inability historically to capture deep quantitative data, whether it's genotypic data or phenotypic. And I think largely the three big buckets or tools for precision health will be medical imaging, genomics, and blood biomarkers. And if you think about the costs associated with those buckets or those tests, they're falling rapidly. So whole genome sequencing, the first genome was sequenced in the year 2000. The US effort and the global effort to sequence that first genome was $3 billion. Craig Venter, who's a co-founder of our company through Celera, was $300 million. Today, whole genome sequencing for an individual costs $1,000. It's falling faster than Moore's law. We predict that in a couple years we'll have a $100 or $200 genome. Similarly, medical imaging, to capture imaging biomarkers across the whole body. Just a couple years ago, it was a 2-hour ordeal to scan across the whole body. Now it's under an hour at HLI if you come through. It'll be under 30 minutes, probably trending towards 15 minutes in a couple of years. So all of these tools, the costs are coming down, the time is coming down, and I think as the costs come down, our ability to kind of democratize precision health actually goes up. So I think our ability to work with sort of nimble governments, maybe it's the UAE, maybe it's Singapore, sort of smaller, nimble governments who want to introduce precision health or preventative health on a sort of global national scale. I think as these costs come down, our ability to democratize this goes up.
Michael, I know you had great activities in diabetic retinopathy, for example, in India, in Thailand. So this also links to your emerging market activities as a global company. So can you shed some more light on that?
Yeah, I think that's a good concrete way of the way that we think about it, and it links back to your prior question about how do we think about partnerships. So let me set the stage a little bit. So diabetic retinopathy, fastest growing cause of preventable blindness in the world, leading cause of preventable blindness among working age adults. Screening prevents blindness in diabetic retinopathy because treatments work, but screening is very difficult, and even most physicians can't do it. So if I asked in this audience, how many physicians in the room? Some number. How many feel comfortable looking in the back of the eye and saying diabetic retinopathy, yes or no? Yeah, so nearly everyone puts their hand down with that. So I'm a physician. I definitely am not competent to do that. So if you look at that, that means that many people worldwide go blind because they can't get screened. We sometimes talk about it as, oh, it's in emerging markets, but actually there are disparities in the United States where many people go blind because of diabetic retinopathy. My family is all from the middle of nowhere in Alabama. My grandmother went blind from diabetic retinopathy. So our team said, this seems like a place where if we knew what world-class ophthalmologists, like people from the Cleveland Clinic, how did they look at the eye, we might be able to train an algorithm to actually detect that. That worked. It was published in JAMA in December of 2016. Then one of our partners is the Aravind Health System in India. And they were really interested in how do we actually deploy this. And there's a long distance between how do we publish a paper and how do we make something work in the real world. There is an estimate that in India you would need 127,000 extra ophthalmologists just to look in the back of every diabetic's eye every year. That's crazy. You can't do that. And similarly in the United States, in many zip codes, we have very bad compliance with the retinopathy screening. So we've been working on how do you reduce that algorithm to working on a device? How do you make the device usable? How do you get the device CE marked? And then how do you deploy it? And we've worked with Aravind in India and then with a hospital with the Ministry of Health in Thailand to do exactly that so that we learn how these things interact in the real world so that we can make them better so that people who today, almost half of people in India who are diagnosed with diabetic retinopathy are diagnosed with some degree of blindness. We should all find that offensive, just like we do in the United States.
Thank you. That's a great example. So my next question to all of you would be, because you are coming from like different companies with different business models, especially Alphabet has many different arms in healthcare right now. SaaS is more like a B2B company. The consumer knows probably very little about SaaS. And HumanLongevity is right in the middle. You do industry partnerships and you also touch the lives of the end user, consumer who is not sick. So there have been a lot of investments made by all these companies into AI, in precision medicine, but also in order to exemplify that it may not be a hype and it's a sound financial investment, I would like you to all explain from your vantage point how your financial returns will look like. Are they good investments? Are they long-term investments? Are they high-risk investments? So how do you describe those? David, let's start with you.
Yeah, we're increasingly partnering with self-insured corporations, and so there's every incentive as they're managing healthcare costs to get costs down. Again, if you think about, identifying disease at stage 3 or 4, prostate cancer, lung cancer, Alzheimer's disease, diabetes, coronary artery disease, that's quite expensive. And that's why, in general, our system, unfortunately, if we progress, will become 17% of GDP, 20% of GDP. So it's not sustainable. So compare that, though, to identifying, pre-diabetes at its earliest stage, or coronary artery disease when you first have the, very first speck of calcium, long before you've got a stenosed coronary artery. The costs associated with identifying disease at stage 1 versus stage 3 or 4, that delta is massive. And it's probably about 90% cost savings. Now, our stats at HumanLongevity show that for folks in whom we're making a clinically significant life-altering finding, that's 14% of our clients, we're extending their life by anywhere between 1 and 10 years. And our median age is 52. So we're extending the lives of folks in the prime of their health and the prime of their work experience. So if you can extend someone in their 50s or 60s or 70s another 10 years and give that person an additional decade of healthy sort of human lifespan, you're also contributing to the national wealth and the national GDP. In our country, the per capita GDP is around 50 to 60,000. So you add, 10 years of life to someone times 60,000 times 100,000 people. And now if you're evaluating a cohort of folks, call it 100,000, that's $25 billion in value that we're adding to the system, both in terms of cost savings, but also in terms of contributions to GDP. And if you're a self-insured corporation, it's the same calculus. If you have employees, not just 2 or 3 years, but 5 or 10 years, you're going to be massively reducing costs. So for us, it's the only way, it's really our reason to exist, and really our investments in AI and machine learning are sort of predicated this idea that we're going to help get our partners' costs down, and whether that's a national healthcare system with a small country, or a self-insured corporation, or a health insurance company, those are our partners.
Thank you. Steve?
So we look at this 2 different ways. So we've been working in this space for a long time. We're asked by all the healthcare entities around the world to help them understand value-based contracting. What does that look like? What does the data look like? How do they make decisions on that? We then also are asked on the provider side and the integrated delivery network side to understand operations and to improve that. So I think we have to look at it through both lenses. How do we identify what we can pay for? What's the best use cases to be able to do that, and how is it implemented? Like, for example, the way Cleveland does it for heart patients and many other specialties. We know what that looks like and what good looks like. How do you replicate that using AI, precision medicine? And then how do you automate that across systems? Because right now, I can't, in many systems, identify all the x-rays or images on an individual, much less than use AI machine learning to then make the next best action in that space. So a lot of our work is looking at this across the ecosystem, bringing in everything from appointment scheduling to IoT devices and all of the information that's on the edge to give you the best understanding of that patient process, including, immediate savings in workforce dynamics and staffing and all the models as far as what that looks like. Then going back to the other side of the system and saying, this is what we think good looked like and this is what it cost. How do we then start understanding how to pay for that across the system? If we get those incremental savings out of the system, then we'll actually be able to pay for more of these automated processes and precision medicine that we're describing.
Thank you. Michael?
So from a couple of years ago, there was a brilliant health affairs paper that estimated that annually, globally, 8 million people died due to lack of access to high quality care, things that are already known and already discovered, and that cost $6 trillion in lost welfare. In the United States, we spend more than $3 trillion a year on healthcare, a third of which is waste. And I think anyone who has practiced knows that feels like about the right estimate. So I think we're convinced that, number one, we have to be in this for the long haul. And number two is that as we help make lots and lots of people healthier, that will create value.
So we just received an interesting question from the audience, which links to this, I believe. There has been a big inflow of capital into health technologies, yet it's unclear whether people are actually healthier overall. Like with all these investments, also in hindsight, do you see we get healthier, or?
I think if you looked at systematic reviews, in particular of health information technology so far in healthcare, it's cost a fair amount of money, and the improvements in quality have been small, and that is one of the things that at least I think we believe can change, but we need to show that it changes. The history of, but Bob Wachter, who's the chair of medicine at UCSF, and I wrote a piece for JAMA about 1.5 years ago about the productivity paradox in healthcare, that now healthcare is digitized and productivity has not gone up in the same way that you would have expected. It turns out that you've seen that in industry after industry after industry, the productivity paradox of something transformational and new comes in, and it takes 10 to 20 years before the productivity goes up. It was first seen in the electrification of factories in the US. If you look at when healthcare became digitized in the United States, at least, we're right at about that inflection point. And so what Bob and I wrote was that we are, for the first time, really hopeful about this and optimistic. But I think the questioner is right, that people should have skepticism about it. I don't know if other people have different opinions.
Yeah, well, our company is HumanLongevity, so I have my bias. But the reality is, if you look at the average life expectancy in the U.S. over the last 100 years, it's this nice, more or less kind of linear curve, except in 1917, where there was this big dip, and that was World War I and the influenza epidemic. So everyone get your flu shot, right? But actually, as many of you know, in the last 3 years, starting in 2014, we've had a 3-year dip in life expectancy in the US, and that's also happening globally. And part of that's the opioid epidemic, part of that's liver disease, part of that's suicide. But that's not a good fact for our country when we're spending $3 trillion in our healthcare system and our life expectancy is declining. So I think people have a right to be skeptical. And I would argue that the reason why, that we're, at least in part, that we're getting that decline is we're investing in the wrong spaces, in the wrong areas. We're still investing largely on the reactive treatment-based side, the sick care side of healthcare. And we've really got to be investing much more than 2% in the preventative side. And I think until we start investing significantly in the preventative side, honestly, I think we'll probably start, continue to see either a plateau or a continued decrease in our life expectancy. But I think on the optimistic side, I think if we do make the change and pivot, I think there's no reason why each and every one of us can't live to the age of 100 and live to the age of 100 healthily. At HumanLongevity, we have this saying, and it may sound a little cliche, but we don't think so. It's that people, our clients, should die doing something they love, not of disease. And I think that is not hyperbole. I think that's actually attainable. And it's this whole idea of becoming previvors, pre-symptomatic diagnosis. It's staying largely out of the sick care system, staying out of the hospital system. Maybe you live to 110 and you never, ever see a hospital. That's the goal.
Thank you. Steve?
Yeah, I think what we're seeing is that in pockets, people are doing really good work, right? And so for things around cardiovascular disease and protocol management and that type of thing, we see fantastic work. You brought up the opioid epidemic. We do a tremendous amount of work in that space. The CDC data for the opioid epidemic is collected in SAS, but that data is not made operational. And so as you look across the life expectancy decline in that population, what we have found is you have to bring in a lot more data. We can't count on EMR systems and other data sources to be the sole source of truth in this space. For example, in the Commonwealth of Massachusetts that has seen a reduction, we had to bring in first 10 data sets over 5 agencies and then 26 data sets over time to really start bending that curve where they even saw a 6% reduction in deaths. And that was primarily in a corrections population where we changed policy. So I think we have to look at what are we doing well, how do we educate everyone, and then how do we change the policy, right? SAS, we say that a lot of people look at data and see numbers. When we look at data, we see faces, and we understand that patient journey, and we think that having analytics to be able to drive that journey is a much better way to take care of the patient population.
Thank you. We have just a couple minutes left, so instead of asking my deep regulatory question, I would like to ask you, again, something related to what came from the audience and what really my curiosity lies. So what would be the next best thing you would invest if you have the technology, if AI is in your toolkit, which we now know it is? What is the next big thing you would invest with that toolkit? Steve?
Sure. So right now, we have a huge challenge. Let's take the U.S. with interoperability and mandating investment in that space, whether it comes from the federal agencies or payers. To drive that change, the investment that we need there is to mandate that interoperability happens, right? We actually work in the health information exchange space, not by choice, but because we took over one that was failing. And if people had that data and used it, it would make a difference in our patient populations. So we have to invest in interoperability. What does that look like across the whole ecosystem, not just in the US, but across globally?
Interoperability, David.
Yeah, I think in general, investing in kind of deep quantitative testing, because I think that's the substrate that AI and machine learning needs. Again, I mentioned this statistic, 40% of presumed healthy individuals that come to see us have clinically significant findings. How many of those findings could we have gotten from a superficial sensor or wearable? I love my Fitbit and Apple Watch, but the answer is 0. So it turns out to actually drive precision health, you've really got to have deep quantitative testing. And I think investing and driving down costs in medical imaging, mostly MR-based, whole genome sequencing, and advanced blood biomarkers, metabolomics, proteomics, I think that's going to be very important.
Thank you. Michael?
Yeah.
I know you are investing everything in a billion people scale, so.
I'd agree with Steve. My mom died last month after a short battle with gastric cancer, where she moved from her sort of local health system to a quaternary care referral place. And I know this as a hospital and health system executive. I know this as a Google person. I know this as a health services researcher. But interoperability really matters, and the failure of interoperability wastes people's time, and it wastes the time of people who are dying, as well as the people who could be healthier. And so I don't think that I could say it better than Steve, but it's been brought into really clear focus for me, I think, recently, the way that hurts individual people. And I think the last thing that I would say is AI is so hyped right now that if there's one thing that I would say, as you or as other people are thinking about investing in AI, is treat it with your native skepticism that you would bring to the table for any new device or pharmaceutical or other things. There are lots of things you don't need AI for. There are lots of ways to get it wrong. And that having a little bit of skepticism around the claims that you hear that AI will tell you the right way to treat every patient every time just out of historical data, bring your native skepticism to the table. It's math, it's not magic.
Thank you very much. It was great. Thanks everyone for being with us, and let's look forward for what's next. Thank you.
Thank you.
Thank you, everyone.